Okay, I think we can get started. Thanks for joining us again. This is our introductory slide, and we have Dr. Tarabichi here this morning from MetroHealth, and we're delighted to have him. So just another reminder, please avoid using private health information. Next slide. This morning, I will facilitate as usual. We have case presentations from Amber and Dr. Spear. Adam, unfortunately, will not be with us today. But Yasir has agreed to present about EHRs and clinical decision support, all those things that are near and dear to my heart that I've struggled with for many, many years. Our discussants will be Mary Lee, which I think is very appropriate, given we're going to talk a little bit about pharmacotherapy and also about lifestyle changes in diet. So Chris will weigh in as well. Next slide. Usual information about assistance and contact information. Next slide, please, Rick. And these are the disclosure statements, and I don't believe there are any changes. Next slide. A reminder you to use patient-centered language, which I think we've gotten quite good at. And next slide, please. And we are ready to go. So Yasir, take it away. Thanks for joining us this morning.
Thank you for having me. So I'm going to say full disclosure, I'm a pulmonary and critical care doc. So when I have to rethink some of these EHR concepts through cardiology, it took me a minute. But I'm also a physician informaticist. And so clinical decision support and predictive analytics and population health are what we deal with on a regular basis at MetroHealth. So I'm going to jump straight into it here because I know time is short. These are the learning objectives. We're going to start with talking about the general role of the EHR and identifying, assessing, and risk stratifying and caring for patients at increased cardiovascular risk. I'm going to talk briefly about clinical decision support as a general concept, and then we're going to talk about the incorporation of social determinants of health data into the EHR and what value that delivers. Okay, so we'll just jump right in here. So what is the use of an EHR, particularly with regards to identifying and treating patients that are at increased cardiovascular risk? The figure, by the way, in the corner is one of those AI-generated art pieces where I put in doctor using data to treat patient, and that's the freak show that you get. At a high level, right? Thinking about the tools that are available to us, we have risk-based patient registries, usually disease-specific. We have risk-driven clinical decision support systems. So these are prompts or interventions that are based on data at the patient level. You might translate that to your system as a best practice advisory or BPA, or health maintenance topics, those things that you see that remind you to get colonoscopy screening, for instance, for your patient. Moving a little further down that gradient, there's more individualized decision aids. These tend to be patient-facing, and it tends to be a shared decision-making activity. And I'm going to show you an example of that. And then kind of at the end of it is one of my passions. It's self-service data tools. And so the one that I'm going to show a snapshot of is going to be Slicer Dicer, a little bit epic-centric, but it should give you a sense for what's out there. So I'm going to start with the caveats here. Living in the EHR, and I'm sure those, all of you that have touched EHRs know this. So the promise really is that they have rich contextual data about an individual's health and life experiences, and they're ripe for model building with minimal cleanup or input. We all know the reality, right? It's a highly biased secondary data source with variable data quality and completion, and then highly reflective, unfortunately, of the reality of the world, which is systemic biases and missingness not at random. So again, just kind of moving along with the cardiovascular risk example, I went straight to the statin, the statin conundrum here, which is prescriptions of statin based on cardiovascular risk as perceived or calculated. And this is just kind of the flow chart that I pulled lazily from UpToDate. I don't do this on a regular basis, but it seemed reasonable and consistent with what I've been hearing about in the guidelines. And I looked at it from an informatics perspective and thought to myself, so, what is it that an EHR can step in to do? And I'll just tell you kind of right off the bat, this is a problem with a lot of guidelines and suggestions. Translating these into very, discrete logical items for what to do when you have data or data is missing or how long is the look back period gets problematic. So, evaluate family history for, for a patient. Again, tons of missing data, unclear how to even pull that out. And then coming to the cardiovascular risk stratification, there's that middle piece of a shared decision making when the risk is low to moderate. which again, is not going to be easy to activate or automate in the EHR. And you can argue that if you have the data that you need, that you can probably capture the greater than 10% risk relatively easily. And so carrying this on a little bit further, do we have tools today in the EHR that help you calculate your actual cardiovascular disease risk, your ASCVD score, which is a risk of stroke, MI, or cardiac death? At least in our electronic healthcare system, we do, right? It's a known calculation. It's not a black box. But I went ahead and just dumped one of our notes in here, which is it's a .ascvd for those of you that are on Epic. It pulls in a table that the calculation at the top here is based on, and that's the 13% that you see in bold. And right off the bat, right? So think about the fields that are problematic here. Age and gender, I think we're going to trust for the most part. Race is not a self-identified construct in the electronic health record. A lot of the times it's something that somebody at a desk just suggested a patient is. Highly problematic there. I have a lot of work on smoking history, and I can tell you it's junk across the board. So that's another one that's tough to trust. A little bit easier to go with diabetes, hypertension. Looking at things like blood pressure, cholesterol, HDL. I mean, what's the look back period? What was the quality of the test that was obtained? That's another problem. The blood pressure, as we know, is all over the place, especially if you're looking at an office visits. And so immediately you can start to realize that this one-time snapshot of somebody's cardiovascular risk is problematic, right? So that's the problem with guidelines suggesting we use something specific, which doesn't translate into the electronic health record really well. It's a fault both at the development and propagation of societal guideline levels, as well as the electronic healthcare system really not capturing these things very well, just presenting a dump of information which with questionable quality. And even if the model's right, even if the variables are right, I'm just going to go ahead and pull in Adam and Jared's paper here. So this is a paper that looked at cardiovascular risk prediction using full cohort equation, which at the outset we all know is biased, and looking at how the model does in different neighborhoods based on area deprivation indices or neighborhood disadvantage. And the bottom line here, without getting too much into the details of the slide, is it performs more poorly in higher deprived neighborhoods, which really shouldn't be surprising for anybody. So a piece of information, again, just to throw more kind of blurriness and fuzziness in front of you here as you're thinking about implementing models like this in the electronic health record. And so, okay, let's just pretend that the data is perfect. Just thinking about this from an operational perspective, from an informatics perspective, is a registry the right idea? A list of patients that have a sense for cardiovascular risk with a calculated score. I think that's good for panel management, but really at the patient to provider level intervention, not really the right time or place. We can think about clinical decision support. Those are the pop-ups we talked about. I'll show you an example of a shared decision aid. And then I think for the data self-service model, personal panel review is a really good choice. So, and I'll show you how I did that on my patient population in Slicer Dicer. Jumping to point number 2 here, I'm trying to follow the plan here. So we're going to talk a little bit about clinical decision support, and I've looked at this from the American Medical Informatics Association Clinical Decision Support web group and the publication note at the bottom. The basic idea: CDS enhances health-related decisions and actions, empowers clinicians, patients, and other stakeholders by enhancing clinical decision-making and clinical processes. I'm going to read this out: improving the quality of healthcare services and patient outcomes. Put simply, CDS provided by a machine should enhance the experience and the outcomes beyond just the individual without the machine. Anything else is a frustration. Anything else is best avoided, essentially. These are very basic concepts of clinical decision support that we have as informaticists hold dear, but unfortunately don't typically always comply with. It makes sense when you think about it. These are the 10 commandments published far back in 2003, Bates 10 commandments. Speed, real time, fit it into a workflow. Usability is really important. You guys will like number 5, physicians resist stopping. So if you've already started to do something and you throw a best practice learn in their face, they're probably not going to change their mind, but it's easier to change direction and pivot. The simpler the intervention, the better. Only ask for input if it's actually going to change anything. don't unburden your users with more clicking, needless clicking. And then the really important ones are 9 and 10. It's monitor, impact, manage, and maintain, which is something that unfortunately a lot of organizations struggle with. And then that right-hand panel is just giving you a sense for these are clinical, these are evidence-based, support, if you will, of these theorems. These are the things that worked in these studies. So here's the problem with CDS. We all know this, right? Alert fatigue, workflow disruptions, and just from an evidence-based perspective, the impact of CDS has been historically small to modest at best. We think that we can change direction. We can make everybody, stick with guideline concordant care. It's, piece of cake, throw up a couple of BPAs, but unfortunately, reality doesn't always work that way. Generally, the acceptance though from the clinician side is as long as clinicians feel that your CDS intervention is useful, they'll go with it. And so that's we're not horrible people. We will generally accept the help as long as we find it to be helpful. Once you add predictive scoring to the equation, it gets messier, right? So that last slide set was about clinical support. Just here's a thing, here's what I think you should do. Now we're saying here's a risk score, act and behave, as a result of this calculation that I provided, which with recent FDA regulation actually is technically now a device and needs to be FDA regulated. So I think that predicts a risk for us, an outcome. Generally, as soon as you add a model, it gets more vague. Clinicians start to get a little bit worried, right? So they're generally interested, on the plus side, generally interested in prediction-based CDS. We're naturally Bayesian in our thinking, right? We think about probabilities, even if we're not really thinking about probabilities. But we as clinicians prefer scoring with mechanistic risk factors. So think about Chad's VASC. It just makes sense, so we run with it. If you just replace that with a single score and say, don't worry about it, I figured out this is the risk, we're going to have a hard time assimilating that. And then, honestly, this is something that I've struggled with a lot in our own implementations. I put up an ROC curve and everybody freaks out. I mean, we struggle with basic statistical concepts, even the ones that we drive through our testing, like sensitivity, specificity, positive and negative predictive values, and then more advanced things like discrimination or calibration. And then, like I showed you in a prior slide, we are generally worried about exacerbating disparities when we start to introduce more complex models. So jumping back into the statin example here, this is a kind of a recent publication, 2020, for a statin intensification CDS that compared a large number of patients in Pennsylvania and New Jersey, presenting either a passive notification, so a little tickler, versus a pop-up that interrupts the workflow for people that are high risk based on the ASCVD risk score. And the bottom line here is, not surprisingly, there was no difference in the main outcome of statin prescription or intensification, which is, again, disappointing, but not shocking. When you dive into this paper a little bit more, it sounds like one of the major issues they had was actually communicating the whole point of this intervention with their cardiologist, which is an interesting problem in hindsight. Socialization is everything in informatics. Moving along that spectrum of decision-making from the provider to the patient and the provider, we have shared decision-making. This is Montori's statin risk choice application. It's you go to the website, you can use it. You put in a couple of variables for the patient. It takes maybe a minute and a half if you have to look up some labs. And it'll present you with this pictograph of, here's the risk of having a heart attack without a statin. Here's the risk of having a heart attack with a statin. And the blue happy faces is basically that kind of the number of lives saved, if you will, or the heart attacks prevented, I should say. You click again here and it'll give you the risks for being on a statin, which again, I think coming from the lung cancer screening world, I can tell you, I love to try to get into these discussions with my patients, but they just kind of look at me and go like, just do it. Just tell me what you want to do. If you're talking to me about lung cancer screening, you obviously care about lung cancer screening in my case, because to be honest with you, when I have people that are really sick that I don't think are good surgical candidates, I don't even bring it up. So they're not wrong. Unfortunately, it's the reality, and this takes time, right, from a busy visit. And consistent with that, the tool in randomized control studies has showed, from a patient perspective, improved knowledge, trust, decreased decisional conflict, which if you do any of these medical decision-making interventions, you know that that's generally true of most interventions, right? The fact that you spend extra time with somebody explaining something, they're going to feel better about their decision, whether or not they're making an informed decision necessarily, right? But here's the catch: uncertain to no improvements in compliance and clinical outcomes. And so we're back where we started. The final example I want to give here, because we're running quickly out of time, Slicer Dicer is our data self-service tool. You hopefully should have this or similar tools at your institution. I know people that are, for instance, using Trinetics can use Trinetics. I looked at, this is kind of an easy to click around querying tool, which counts cohorts, and you can look at patients, particularly if they're your own patients. And I was able to pull in, patients on the active patient registry, meaning they've been seen in our healthcare system. I was able to pull in the ASCVD risk score, which was awesome. So when it was calculated, again, no idea about the data quality, but it's there. And then I was able to exclude people that are on statins or have allergies to statin, and those are the red boxes. And limited only to patients that I've seen, which is a little messy because obviously I see patients in the ICU, and so I don't necessarily own them, but it is what it is. And amongst that cohort, which was a much larger number, I came out with 43 patients that looked like they should probably be on a statin. Now, I can tell you, having done this before, unfortunately, is if you showed this to somebody in the executive suite, they'll say, oh my God, we need to send letters, we need to contact these patients. Why are their doctors failing them? I've seen this with colonoscopy screening. You start clicking into the charts and you can see that the primary care doc is like going full speed at this. Oh, you need to do this, you need to do this, you need to do this. And the patients are like, nah, I'm good, leave me alone. And so this does not mean it's a failure of the system per se, or a primary care provider. Unfortunately, that's the assumption, right? A primary care provider failing to do their job. This, I think, is why I would relegate this tool to more personal practice reflection. If I know these patients, I can click on the list, which obviously is hidden now for PHI purposes, and I can say, oh, I know these people and I've tried. Right, so that I haven't failed anybody. Or maybe there's a misattribution, for instance. Someone looks like they're my patient, but they really actually aren't. And so it's a decent tool for clicking around and understanding your own patient population. And I'm all for empowering providers with data for especially when it's their own patients. And so at the end, I'm going to talk briefly, and unfortunately briefly, about the incorporating social determinants of health data to the electronic health record. We are very aggressive about this at MetroHealth. We've introduced standard social determinants of health screening questionnaires and included some additional ones from our own, primarily around digital connectivity, kind of cobbled together a couple of standard plus other questionnaires. And we do this intake on a regular basis with the intent of connecting people to interventions through Unite Us and other community-based organizations. And this is the Social Disparities of Health Wheel, which, love it or hate it, it's kind of here to stay, which gives you a sense, if you stare at it long enough and you understand the kind of hieroglyphic here, like, where the problems might be. And this we ask this for everybody coming in. We ask them on their patient portal, fill this out, and it just kind of completes as you go on. We've actually done I want to say over 100,000 patients have this information in our system, which is a pretty sizable number.
Wow.
And, our group, not myself, but Ash Siegel and some others have published on the intervention here. And I'm just going to jump straight to it and say lots of people referred, not a lot of people that actually got the connection, because it turns out that your CVOs are actually struggling to fill an already existent need. They're not sitting around waiting, right, for patients. But still, if it's 850 people that want help with food, 100 received food, I mean, that's great. The other part of why the social determinants of health are important, going back to Adam and Jared's paper, honestly, it's great to have area-based indices of socioeconomic deprivation. Like, it's nice to have that. We can pull that. We have patients' addresses, but it's different to have actual individual level SDOH, because that contributes to the calculation of individual needs and risk at a significant level. And this is just a review paper that goes through a bunch of models that incorporate individual level SDOH, again, that wheel, versus just here's where you live, so here's what I think your problems are, to show that it's substantially more important to have that. And we'll stop there. Thank you.
Wow, thank you, Yasir. Fantastic presentation. So
Sure.
I had a couple of comments and we'll open up the questions. So I sit on the Health Information Technology and Research Study section at AHRQ and have been there for a number of years. And it's interesting that a lot of the proposals are put together by informaticians, not people like you and me. They're not physicians. It's almost technology in search of a problem. So it's a new clinical decision support tool or calculator. And we've gotten so tired of it, we're looking for other approaches. So one of the things we talked about, and I think you outlined the limitations of CDS quite well, is peer motivated behavior change among physicians. Alerts that say, did you know that Dr. Tarabichi is prescribing statins for patients like this? Something you ought to think about. And boy, that's going to change my mind about what I actually do, or have a discussion with the patient. So that's one approach to it. The other thing I think you pointed out was our risk assessment calculators and how they work into shared decision making. A lot of our patients, especially our Medicaid beneficiaries, do not have the numeracy skills to understand. And your experience is the same as mine. You used to tell us to use number needed to treat, which is ridiculous. But even the visual aids don't seem to have much impact. So I'm glad you highlighted these problems, I think, and we've got to look at some other ways of going about it. So thank you.
I unfortunately, as I was putting this together, just got more and more depressed. But yeah, you're absolutely. I mean, we need a better way. And I was just at the American Medical Informatics Association conference in DC. Got back yesterday, and it's exactly that. It's a lot of tech solutions for problems that either don't exist or we fail to solve using exactly very similar tech solutions.
Right. Thank you. Any other questions?
If nobody does, there's one piece that I missed in hindsight, and I think digital therapeutics is something that I didn't talk about, but I wanted to focus on this statin. I think identifying risk and then sending patients kind of lifestyle intervention based digital therapeutics, like even just an app that helps you do something better, is probably less explored, but maybe equally as important, just in terms of coaching. So I would probably add that in there in hindsight.
Great, thank you.
This is Debbie Gordish from OSU. How at your institution are you getting the statistical information to the actual practicing physicians? Because at OSU, we have some ways within Epic that we can get into all of our own personal data, which goes down to individual patient data. But I would bet maybe 10% of the primary care providers actually go into it on a regular basis. How do you guys promote it, and how do you guys have any data on the percentage of use?
So we have a lot of dashboards that people build primarily for concepts that unfortunately are tied to reimbursement. Like at the end of the day, it's like, how am I doing in this, meaningful use, like chart reconciliation or med reconciliation. Unfortunately, it's driven by the business and less by, our drive for quality. Now, there are dashboards for quality, but they're obviously, they're less prominent, I would say. People are clicking on those less. The tool that I showed you at the end was the data self-service tool. And at our institution, we have an open access model. And we're just like, everybody is entitled to look at this data. And we, there's a little bit of it. It's a trust exercise because you don't want people to be able to download, for instance, tables and tables of their patient information, but we decided to basically, with some limitations, just allow it. We thought it was important. So our mission is to empower providers with access to their data so that it's not this like, I only see patients when they show up, or I have to click through 700 charts to figure out what's going on. That's a model. The data self-service model is still evolving. The tools are still evolving, but I would say they're all evolving for more functionality. I would hope most places have looked into that. And a lot of what the informatics team does here is we teach people how to fish. So we set up training sessions where we go, hey, come just click around. And I learn every single time, even though like we designed the system, but I'm like, oh my God, how did you do that? That's great. So it's been awesome. And I would say it's hopefully the wave of the future.
Thanks for your question, Debbie. Any final questions? We're almost at 8:30, so So thanks to everyone, and thanks to Yasir for joining us this morning with this very informative talk. So back to Claire for a moment.
All right, thank you. So last chance to sign up. The cardio webinar is a week from yesterday, Wednesday, November 16th at noon. We would love if you all joined us. Next slide, Rick, please. And then everyone should have received an email this morning during clinic from the cardio account in general about the spring echo clinic. So we do have about 7 people signed up already, which is about half of the cohort we usually accept. So if you are interested yourself in joining, we do suggest registering soon. And then we would also appreciate if you could forward that email you got onto your networks of people that you think would be interested or would benefit from echo. You should also have the survey in your inbox. We appreciate your feedback, and we will see everybody next week.
Thanks, everyone. Enjoy the rest of the week. Bye-bye.